This last week, we treated and evaluated a patient who was in a head-on motor vehicle collision at high speed and unfortunately suffered a severe head injury. So what do we do in the hospital specifically to manage a patient with a severe head injury? Severe head injury is defined by the Glasgow-Coma scale. It's a way of looking at a physical exam of a patient that's been in a bad accident or hit their head. And it takes into account their ability to open their eyes, to talk to you, and to follow commands. Patients with the Glasgow-Coma scale of less than 8 are defined as having a severe head injury. We also take into account what the head CT shows. Is there bleeding? Is there bruising of the brain? One issue with patients that have a severe head injury is that they can encounter swelling of the brain. When swelling occurs in the head, the skull is unforgiving. It will not expand. So the swelling pushes the brain to the side or pushes it over. Or it's general swelling and the pressure inside of the head goes up. When the pressure goes up, then the brain does not function as well and can also cut off its own blood supply, meaning the patient can be subject to having a stroke. So one of the key principles in managing severe head injury is managing the intracranial pressure. How do we manage the intracranial pressure? Well, just like with spraining an ankle, we want to elevate the head to allow the venous drainage to decrease the swelling. So we raise the head of the bed. Patients with a head injury can be agitated. The more they move and the more they're agitated, the more the pressure goes up. So we give sedation. Sedatives can help with the pressure. And some patients will think, or patients' families will think, well, we're inducing a coma. We really rarely, if ever, induce a coma, but we do give some sedation so that the pressure is better managed. We also like to monitor the neurologic exam, because if the neurologic exam is improving and the patient's following commands, their pressure is likely not high. Drainage of spinal fluid is a very effective way to manage intracranial pressure. If there's a fixed volume inside of the skull and you have swelling, if you take something out of that fixed volume, you therefore lower the pressure. So if you remove spinal fluid, you can effectively lower pressure. Another way that we can decrease intracranial pressure is by dehydrating the brain. And we do this by increasing the sodium content in the blood. That pulls fluid out of the brain. So patients will get extra sodium in their IV to try to do that. Another medication that's used that does the same thing is a medication called mannitol. And it again dehydrates the swelling. It pulls the fluid away from the brain and into the bloodstream and eventually out into the urine. More dramatic ways of improving swelling would be surgical. So if there's a blood clot, we can remove it. And if we want to be very aggressive, we can actually remove part of the skull, which allows the brain to swell outside of the skull so that it's not a higher pressure. Occasionally we'll place a monitor inside of the skull to measure the pressure, called an ICP monitor or bolt. You can also do a drain that drains spinal fluid and measures pressure. If I think the pressure is likely to be high and needs to be treated for a while, I like to put a drain in because I can manage pressure and measure pressure. If I think the pressure is likely to not be high and I just want to make sure, then the monitor is less invasive and can be used to measure the pressure. Severe head injury is hard to predict as far as the outcome goes. And it's very hard on patients' families to know what they're dealing with. In the early stages, the best thing that we can do is manage the pressure to prevent further injury to the brain. Once that pressure and swelling phase is over, then we go more to rehab, and it's in that setting that we have a better ability to predict the long-term outcome.